Hello, everyone. Today we are going to discuss the case of a 58-year-old gentleman who has had a history of type 2 diabetes since the last 4 years. There is also associated obesity, hypertension, dyslipidemia, and there is a clear history suggestive of obstructive sleep apnea. The physical examination revealed that the patient is overweight with the BMI stable at about 32 kilograms per meter square. Blood pressure sitting in the right upper limb was 130 over 82 millimeters of mercury, and the heart rate was 60 beats per minute. The laboratory evaluation showed that the HbA1c was 8.3%, the EGFR was 70, which is of course 70 ml per minute per 1.73 meter square. The LDL cholesterol was 69, HDL was 35, triglycerides 250 milligrams per deciliter. The patient is currently taking metformin 1000 milligram twice a day, lisinopril 40 milligram once a day, metoprolol extended release 100 milligram once a day, atorvastatin 40 milligram once a day, and aspirin, which is basically he's being protected from different angles. So, if you look at this patient's profile, he has a short duration of diabetes, he is young, and up to now he has had no major comorbidities with no major complications that would reduce his lifespan. He is at low risk for hypoglycemia. And considering all these factors, he would benefit from a relatively stringent HbA1c control goal. He is also obese, hypertensive, hyperlipidemic with associated obstructive sleep apnea disorder. And these factors also need to be considered when we decide on therapy. If we look at the ADA recommendation, a HbA1c of less than 7% is a reasonable goal for most non-pregnant adults. In addition to efficacy, the following considerations predominate in determining the pharmacotherapy for him, such as the risk of hypoglycemia, weight loss, or meaning we need to achieve weight loss or at least minimize weight gain, need to prevent or give concern to heart failure, atherosclerotic cardiovascular disease, CKD, and of course, also very importantly, the cost of medications. This patient is willing to start another medication, but is concerned because he sometimes forgets to take his pills and fears that additional pills might only make this worse. He does not want to have injectable therapy. Fixed dose combinations have often been very helpful in such situations because they may improve patient adherence due to their once daily dosing, less complex treatment regimens, fewer pills, improved side effect profile, and of course, better adherence. People with type 2 diabetes commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. Monotherapy cannot address these multiple defects and often leads to failure to maintain glycemic control over time. The current diabetes guidelines encourage early adoption of oral combination therapies while simultaneously emphasizing the importance of individualized treatment. ADA recommendation is that in appropriate high-risk individuals with established type 2 disease or type 2 diabetes, the decision to treat with a GLP-1 receptor agonist or SGLT2 inhibitor to reduce MACE, that is major adverse cardiovascular events, hospitalization for heart failure, cardiovascular death, or CKD progression risk should be considered independently of baseline HbA1c or individualized HbA1c target. So these two groups of drugs need to be considered regardless of what the HbA1c is. Empagliflozin linagliptin is available as first-in-class treatment in SGLT2 inhibitors and DPP4 inhibitors combination group of drugs. SGLT2 inhibitors is a class of novel oral glucose lowering agents that mediates the glucose lowering action by increasing the urinary glucose excretion by inhibiting the sodium glucose cotransporter 2 in the proximal tubule of the kidney. The salutary effect is its ability to act independent of insulin secretion and action and render it suitable to administer at any stage of disease course. DPP4 inhibitors exert their glucose lowering effect by the elevation of incretin hormones and subsequent augmentation of glucose dependent insulin secretion and inhibition of glucagon release. A combination of these agents has the potential to show the additive glycemic control due to their complementary effects. Empagliflozin cardiovascular outcome event trial in type 2 diabetes mellitus, better known as the EMPA-REG outcome study, reported that the 3P MACE outcome occurred in a significantly lower percentage, the hazard ratio being 0.86, with the 95% confidence interval being 0.74 to 0.99, and the statistical value P was highly significant in the empagliflozin compared to placebo on top of standard care. In addition, the safety of linagliptin was further elucidated in Carmelina and Carolina trials. So we know now that not only is the combination effective, but it is also very safe in people who have cardiovascular disease. The HbA1c decrement by the EMPA-LINA combination has demonstrated 1.81% HbA1c reduction at a baseline HbA1c of more than 8.5 at about 24 weeks in people who were already treated with metformin. The benefits on glycemic control were maintained at week 52 in metformin-treated groups, and a higher percentage of patients achieving less than HbA1c of less than 7% were reported for combinations. The combination offers a suitable component in strategy to achieve target HbA1c without increasing the risk of hypoglycemia and weight gain, and with overall improvement in lipid profile. A reduction in the incidence of genital infection associated with the SGLT2 inhibitors has been reported when a DPP4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated. So in summary, the empagliflozin linagliptin combination provides robust HbA1c reduction and 2 to 4 times higher odds of patients reaching the HbA1c goal compared to individual agents, and that too with a much lower hypoglycemic risk.